A 70-year-old man comes up, fever, dyspnea, cough, severe septic shock. We intubate the patient, we start antibiotics. Day 1 to day 3, everything goes fine. The TLC comes down, the serum PCT comes down, the urine output is really good. The urine showed candida growth. PT aspirate showed gram negatives. We treated both. But here's the catch. We tried to give an extubation trial on the 3rd day to the patient because the blood works were really great. But the sensorium was not improving. Starting on day 4th, his urine output starts to decrease, his shock starts to worsen, his TLC counts starts shooting up again. So now we are confused. Out of curiosity, we do a CT head and there we see it. We are looking hyperintensities in half of the ventricle. Now our diagnosis changed. Subsequently, we plan a CSF tap. We did multiple attempts. Then we got the CSF, which was extremely thick and copiously purulent. The reports had Klebsiella in it. We started antibiotics, both systemic and intrathecal, according to the culture. The question was, how did such an important diagnosis get missed initially? So in the meanwhile, we retook the history. One of the history that the patient's wife did not really feel important to mention. Along with fever, he was also having headache, which was initially occipital in presentation and gradually it spread to the shoulder. The patient went to have a massage. The pain started to spread in his back and then lower back. It was not just a musculoskeletal pain, but it was the CSF brewing. So take home message from this case is that taking history is not just a formality. Sometimes the diagnosis is just hidden in plain sight and maybe even in just a slight headache that your patient forgot to mention.